in
zhuzh.
equal parts.
I like a zhuzh. Hi everyone, welcome back to my channel. I am back with the gorgeous Dr. Sam.
Hello.
We asked for a few question suggestions on my Instagram and Sam's Instagram, and we were kind of inundated, so we thought we would just cover the top line of things we are asked the most.
Yep.
Starting with, we both felt we had to start with pigmentation because that seems to be everyone's bugbear at the moment.
Yes, and it was what we didn't cover last time.
Yes, how rude of us.
I know.
So if I go through the various ones I've had,
okay.
So let's do, what is the best way to get rid of old acne scars that aren't really like a deep scar but have got a bit of pigmentation damage from the this?
Self-intervention.
Self-intervention.
Yeah, so post-inflammatory hyperpigmented macules. So those are the flat red or brown marks which occur after the skin has been inflamed. And it's a non-specific finding. Any inflammatory process leaves behind a telltale mark. Exactly. So I think the thing to realise is actually the treatments that tend to improve acne anyway, retinoids, AHAs, BHAs, will help eliminate those marks over time. Anyway, yeah. So the question is whether you actually need to add anything extra in. I think it's important to be aware that post-inflammatory marks do darken up with ultraviolet exposure. Yeah. So don't go thinking that a bit of a tan will help blend everything in.
It's quite the opposite.
The dark bits will darken preferentially, which is a bit upsetting, and that's quite a common finding actually on backs and things. I tend to see patients the first 3 months in what I call the sort of the correction phase, and then if everything is settled and their comedones are clear and the inflammatory count is much reduced and they can remember when they last had a spot and it was 3 weeks ago as opposed to getting blip, blip, blip every day, that's the time to say, okay, we're now in maintenance phase and we can actually think about kind of correcting the problems from the spots that have gone before. And I might change from using a benzoyl peroxide based AM treatment to using something like azelaic acid, which I find to be a really helpful adjunct because A, it prevents comedones, B, it's antibacterial, and C, it inhibits tyrosinase, which is the enzyme that makes melanin. And stops it from making the cells from making too much. So over the next 3 months, you then start to see an improvement in the background sort of uneven skin tone and texture of skin, and even more sort of emphasis on prevention. So that tends to be a really good way to go. So azelaic acid is my go-to for PIH in acne because it is a multitasking ingredient.
And how difficult is it for you to treat someone who has scarring plus fresh, persistent, present acne? And I'm talking about, in this case, I'm talking about proper acne, i.e. you would look at them and go, that's not just one hormonal spot.
Yeah. To be honest with you, people do get quite preoccupied with both the active disease and the consequences. I advise them to park it. Park the concerns about the cosmetic element, because in a way, until you stop new spots from forming, you're just chasing your tail. So there's no point in, until you've got control, there's really no point in focusing on it. As I said to you, some of the key ingredients like retinoids will help with the PIH, but it doesn't make any sense to compromise correcting for the sake of tidying up if you've not got the disease under control.
So if you've got like the odd one and you've got old scarring that's still sort of pink or red, like you said, because I'm asked a lot about acne scars that are already skin coloured and they're deep, and to my mind, you can't do anything with that topically. You're going down a laser road, aren't you?
Sure. So just to make a distinction then, so what we just been discussing are flat reddish brown marks.
And they're the most common that I'm asked about. You know, I would say that same with stretch marks, if it's still pink, you can do something about it, but if it's already turned skin colour and they're old, it's much more intervention.
Together. So a scar, in the true sense of the word, is where there is an indentation. It can be different shapes. There's all different types of scarring. There's rolling scarring, there's box-shaped scarring, and there's ice-pick scars. But that is a different kettle of fish altogether. And I would suggest that is best treated, again, once you've resolved as much of the pigmentation as possible, because more often than not, that's the thing that bothers people the most.
Completely.
I'm a great fan of throwing a lot of energy at things that are easy to fix, parking the stuff that's harder and that there's potential downside to doing something. So treating acne scarring, actual scarring, that is a big treatment.
So you treat the acne,
Engagement, yeah.
then you go in for the pigmentation, and then you go in for the
Correction,
scarring.
beautification, and then see how people feel, because sometimes you give them 6 months respite from actively breaking out, you improve their skin tone, they get comfortable looking at themselves in the mirror again.
Happy.
They don't want the emotional outlay that can potentially go with doing a procedure. That happens a lot in my practice, and I may see a more conservative group of people. But treating acne scarring per se is a big deal.
Yeah. So that's sort of pigmentation that we see day to day from sort of people picking spots maybe, or some kind of damage, whether it's a bite or something. What about the other types of pigmentation sort of down the melasma road that are a much bigger deal, and to my mind you're not going to fix with a cream that's over the counter?
I think melasma is a hard condition to treat. So by melasma, obviously we mean the type of pigmentation that typically affects here, here, top lip, jawline, oftentimes just in one place alone, just cheekbones, just top lip. And it kind of is the bane of women's life. Obviously it's terribly common in pregnancy, it's almost normal in pregnancy, but for a lot of women, especially those of mixed ethnicity, if they're on the contraceptive pill long term, so hormones and UV are the big risk factors. It's much less common in men.
How rude.
I know. And it tends to hang around, the average woman, once she gets it, tends to hang around for over 11 years. So it's, again, a bit like diabetes. I know people don't like that analogy, but that's the nature of it. It needs ongoing maintenance in order to keep it under control.
I have to say, I stuck up for you in that comment.
I saw that, and thank you.
Because it's completely appropriate. My husband's a type 1 diabetic. I knew exactly where you were coming from and what you meant. And when you need constant treatment, no one's saying that it's worse to have a skin problem than to have diabetes. No one's saying that at all.
But it
does give you
the mindset of treatment. Yeah, it's something that needs ongoing
It's
care.
constant and it's persistent. I always liken my husband's condition to, it's a bit like having an orchid in the house, or having a whole forest of orchids, and it's constant maintenance, it's constant blood tests.
Never taking your eye off the ball.
He can never take his eye off the ball, so I totally got what you were saying there, just want to put that out there. So yeah, melasma.
So I have that conversation with women I see on day one to understand that this is not something that you're going to get treatment for 3 months and off you go and that's how you're sorted. Unfortunately, it has to be managed. I find, again, the best way is a multitasking approach with your skincare routine. And I find it is the case that often over-the-counter products don't have quite enough oomph that you do.
I was going to say, they don't have the oomph, do they?
No.
Once you have the oomph, you need a prescription.
Pretty much.
I mean, there are some, don't get me wrong, there are some great serums and creams for people who don't have any specific ongoing issues, and they can be great for anti-aging and da-da-da-da-da, but for fixing something like melasma, you have to go and see a doc.
I think you'll get the best results, most certainly. And sometimes it's just as simple as going through the basics. For example, using proper sunscreen, and by that I mean physical block. Physical block works far and away better than chemical filters because you don't get gaps in the long wave part of the UVA spectrum, which is quite common with chemical filters. And we now know that visible light actually triggers melasma as well. So a good ingredient to look at in sun protection is actually iron oxide. The Aven High Protection Compact contains that, for instance. That's just step one. That's just your protection.
To stop it getting worse.
And that means every 90 minutes to 2 hours, if you're in the sun or if you're in the car, you need to be reapplying your sunscreen.
I get asked that the most. What do you think of these one-a-day formulas? I just want to put that out there.
The problem with them is that they may stop you from burning, but we have no clue what they're doing for your UVA protection.
In
general,
see how it can work all day long.
I don't advocate their use at all.
No.
I think sunscreen should be reapplied every 90 minutes to 2 hours, depending on the level of activity. If you're in ongoing UV exposure, for me, there's no moving away from that. There's no negotiation.
I would say women are much more willing. I say women, but parents in general are much more willing to sort of say, it would be fine for me, it'll be fine, but you would never put sun cream on your baby and expect it to last all day. I would never.
I think you do, unfortunately. I think some of the once daily applications, you do sometimes see it because the kids aren't burning, they're out there in the midday sun, and I think it's terrifying because we know that UVA rays don't burn.
Yeah.
So there's nothing driving you
look old
indoors
when you get there,
or making you cover up. And I think it's always important to remember that sun protection is in that order. It's about covering up, seeking shade, avoiding the strong hours, and then sunscreen. It's fourth in the hierarchy.
Anyway, sorry, I've totally digressed. We could do a whole other video on SPF.
I know, and proper hats. Women with melasma need a proper hat with a UPF rating, not one of your chic little fedora numbers or a baseball cap.
Big proper.
No, and one that doesn't allow light to come through. Helen Kaminsky's a great hat designer. You can get her highly fine, I think, because her hats come with a UPF rating.
Wow, so perfect.
So that's useful, and it's a 3-inch brim you need.
What does that mean? It goes like a
proper hat, 3 inches.
Right.
Yeah.
Oh yeah, so like a big wafty.
Yeah, proper brim. Otherwise, you're not going to get.
Yeah, it won't cover.
Right level of cover. So that's just cover. That's just protection. Then I think everybody needs a retinoid. Everybody needs a pigment suppressor, and everyone needs vitamin C. And you may or may not need AHAs to enhance the penetration of all of the above. So the routine can become quite complicated, but it is the way it works best, because we know that the pigmentation pathway has multiple steps. So like acne, it needs to be attacked at multiple steps.
Throw everything at it.
Pretty much. In a way, you know, obviously
in an organised way.
To a person's skin type, and some will have more trouble than others. And if someone's got thin, delicate skin, I might introduce the retinoid and vitamin C first, and then bring in the pigment suppressors at 3 months. And I have to say, I use a lot of hydroquinone 4% on prescription, because I know that it is 4% hydroquinone. The problem is a lot of people are accessing hydroquinone
from
in less reputable streams, and the
That's
number
right,
might
EU
say
gone a bit crazy,
4 on the packet, but actually if they tested, they frequently found that the percentages of hydroquinone are much, much higher. So another thing to understand is that the pigmentation treatment needs to be rotated, because melanocytes are smart. They get responsive to the treatment that you give them, and they start to produce melanin through other mechanisms. So you actually need to constantly rotate your pigment suppressor. So I will rotate hydroquinone with arbutin, with azelaic acid, even with kojic acid. So that's why it's an ongoing, long-term strategy, and you need to plan. So I often have a discussion with patients: when do you want to be good for? You've got a wedding in the summer, let's focus on using your hydroquinone for that 3-month stint. If it's something in the winter, then we'll coordinate it that way. And of course, winter's a little easier anyway, because people's melasma does often tend to fade. For many, it doesn't go away though, unfortunately.
Yeah, it's still there.
So some kind of a strategy tends to need to be in place at all times. So not an easy one, and probably one I get the most emails about during treatment course. But also important to say the things that I think are a no-no with melasma.
Yes.
Important not to wax your top lip. People will often develop melasma.
I'm not big on wax on the face, personally.
No. Anything that delivers energy to the skin when you're prone to melasma, I think is a bad idea. No, I agree with you. But specifically for that, you know, you get a particular pattern of melasma where you get the top lip, and it's often as a consequence of hair removal.
I've refused treatments on people before, back in the early days of, you know, facials and treatments and waxing. I always refuse to wax eyebrows. I just think it's, you know, being someone who has a very droopy eyelid anyway, and I'm more susceptible to it, I'm just, why would you tear at that area? Just don't do it. And then here,
especially when there are other options now.
Completely. And I was doing, threading's always my first choice, especially for women with PCOS and all that sort of thing, you know, and until you can afford to go down the laser road, if that's what you want to do, I always advocate threading. Just because it doesn't do any more damage. You know, whereas if I go in and wax someone's top lip and they've already got pigmentation, but it's sort of re-educating and saying, you really don't want me to do this, and please don't go anywhere else, because they might do it.
No, absolutely. You know? I think laser hair removal is another one that has to be done with caution, especially again in that area. I think for me, in general, staying away from physical treatments where possible. Microdermabrasion can be a disaster for melasma. And it's amazing how many women, we actually had somebody on the TV show last year, who had gone in for a little bit of pigmentation, and they just kept scrubbing harder because it wasn't getting better, and it just got worse and worse and worse. And by the time she came to see me, she really had full-blown melasma in all those 3 typical areas. Just, I don't know, a lack of experience maybe. Anyway, thankfully we sorted her out with medical treatment, but it was a strong contrast between the outcome of a physical treatment versus slow, steady, methodical medical care.
So nothing on the face, no treatments on the face, or heat treatments or wax, you know, what else do they avoid?
I think, again, laser needs to be done very cautiously. I mean, the problem is that fair skin types who get melasma may also be prone to getting red broken capillaries. And that's a really tricky one. So I work quite closely with someone who has a lot of expertise, and we do things very carefully. And there is a school of thought that thinks if you've got broken capillaries, excess vascularity may even be contributing in part to the fueling of the melasma. So it may be beneficial to actually treat it. But again, that needs to be done in somebody who's got lots of experience, so I wouldn't be popping down to your local spa for that.
No, I'm always a bit wary.
And I think IPL is very risky, especially for things like hair removal if you've got melasma. So make sure you've got a proper diagnosis in the first place, because of course IPL for something like brown spots or soil lentigos, you know, the things that we get in association with more traditional photo aging do respond quite nicely to IPL, so be very clear what the person's treating in the first place.
And I always say, you know, if you're going for laser and you have a suspicion that you have, most people call it pigmentation that just won't go away, you know, and then I sort of say, do you think it's melasma? And Sally Hughes and I had this big conversation a few weeks ago because a big online beauty website had put recommendations for these like £200-300 creams to treat pigmentation, but they were describing melasma.
Right. Okay.
So they were saying, you know, if you've taken the contraceptive pill and you've broken out with pigmentation, but they were making out like these creams that were over the counter that cost hundreds, which of course they then linked to sell, would fix it. And Sally went a bit ballistic because she suffers from melasma. And then we had a long conversation about it then as well, because it's a big frustration for her, you know, that trying to get women in particular, like you said, to differentiate between classic melasma and you've just been a bit unlucky and you've got a bit of pigmentation. You know, I've got some pigmentation on my skin, which I fully expect because I grew up in the South in Mississippi. You know, in the days before SPF, no one knew what sun protection was. We used to use an oil, you know.
And come down on the day 3 whenever you got a bit of colour.
You used to use I remember my uncle and my dad, who I get my colouring from, using like Hawaiian Tropic 4 oil. Exactly, all of those sort of like, you know,
tan enhancers.
Let's just burn, you know. So I'm surprised mine's not worse. I think mine is just years and years of coincidentally using good skincare that it's not worse than it is.
Sure.
But it is a constant struggle for some women, you know, especially younger girls who've gone on the pill and who have a darker skin. Talk to me about a darker skin, because I have a lot of girls who contact me who do have a typical either Afro-Caribbean skin or Asian skin. When I say Asian, I refer to sort of Indian skin. Those tones that when it shows, it's much stronger, it seems to flare up quicker, and it doesn't want to go away. Same treatment approach, just more long term?
I mean, I'm not sure I make a huge distinction necessarily. I think that, you know, different skins will tolerate therapeutic agents differently. You might be able to use more agents together to get a quicker result with someone with thicker, more resilient skin who's quite oily, as opposed to someone who's got thinner, drier, more sensitive skin.
English rose.
Yeah, so those are definitely the cases where I'll struggle, because there simply is a limit to how much their skin can cope with. Yeah. And they maybe can't cope with the active agents every single day. So, you know, that's all a bit slow, and people lose hope a little bit. So I think certainly skin with pigment, and when we sort of talk about pigmented skin, we think about the Fitzpatrick phototyping skin. So skin doesn't really burn, and it ages by developing uneven tone as opposed to necessarily wrinkling in the typical areas that we see. Exactly. So they have different types of aging concerns, and therefore they still warrant proper sun protection, because they hate the brown spots, they hate them. But also they are more at risk of melasma, certainly too, particularly in South America, in certain parts of South Africa, with a sort of mixed race. You know, I think it's more about their psychology. They hate it, they hate the appearance of it, and they may well struggle to get it to cover up as well. They have much greater limitations on cosmetics.
Yeah, well, that's
Isn't it?
outrageous.
I hear this daily, right? Do you hear this too?
Constantly. And I agree with them, it's outrageous.
Such few brands cater properly to dark skin in terms of concealment. So you try to find, because you need perfect colour matching whenever you're trying to conceal melasma. So that's a big issue as well. And then maybe the psychology of wearing sunscreen, that's something that you have to kind of conquer. Because it's like,
well, again,
I don't burn, why should I be wearing sunscreen every day?
Yeah, and also...
And physical block is obviously harder to get.
And it makes certain darker skins go ash.
Exactly.
And they just look like they're wearing a really white sunscreen.
Sure.
You know,
or they look a little bit unwell, it kind of greyish, dulling.
So I totally get where they're coming from.
So I think there are practical issues, perhaps, that I see more with skin colour than maybe actually in terms of the actual treatment regimes changing that much.
But the treatment generally is just each person is so different, you have to just go with the flow.
Yeah, there's a lot of tailoring, personalisation is absolutely key, but then as I say, I think it's nice to be able to give people advice and to, you know, recommend brands, and I suppose it's important to stay at the forefront of which brands are doing, you know, the darker shades better.
Yeah.